Welcome to the Epidemiology Prevention of Vaccine Preventable Diseases webinar or net conference series, also known as the Pink Book series. What you need for today's program is just an internet connection to both view the slides and to hear our audio. The learning objectives for today's program are to describe the different forms of immunity, describe the different types of vaccines available for the diseases discussed. For each vaccine-preventable disease, identify those for whom routine immunization is recommended. For each vaccine-preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice. And implement disease detection and prevention healthcare services such as smoking cessation, weight reduction, diabetes screening, blood pressure screening, immunization services to prevent health problems and maintain health. Today's agenda, part of, again, the Epidemiology Prevention of Vaccine Preventable Diseases webinar series or Pink Book, includes rotavirus and hepatitis A. Our presenter is Dr. Andrew Kroger, medical officer in the Communication and Education Branch, the Immunization Services Division of the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. Continuing education information includes that to get CE credit, you should go to the following website, http://www.cdc.gov/TCEO online, TCEO in caps, lowercase NLINE. And for the live course we're doing today, the credit expires on August 15th of 2016. For the Enduring Archive course, CE credit will expire June 1st of 2018. When attaining continuing education credit, you will be required to provide a verification code, and please watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The presentations will not include any discussion of the unlabeled use of a product or a product under investigational use, with the exception today of Dr. Kroger's discussion of the use of rotavirus vaccine in a manner recommended by the Advisory Committee on Immunization Practices, but not yet approved by the Food and Drug Administration. CDC does not accept any commercial support for this program. A list of resources for today's program, Rotavirus and Hepatitis A, will be available at https://www.cdc.gov/vaccines/pinkbook/pb6.asp. If you have a question, please enter your question to the question and answer Q&A pod you will see on your screen during the presentation. We will try to answer all relevant questions to today's presentation. If we don't get to them, we will answer the questions in writing and post them on our website. Let me now turn the program.
Thank you, Dr. Strickus. So today I will discuss two vaccine-preventable diseases and the vaccines to prevent them. Rotavirus and hepatitis A. Now, the structure of the presentations will follow a recognizable format, with a discussion of clinical disease and epidemiology, followed by a discussion of the respective vaccine, which will include information about the vaccine itself, as well as recommended groups, timing, contraindications, precautions, adverse events, and adverse reactions. So I'm going to begin with rotavirus. And for those of you following along in the 13th edition of Epidemiology and Vaccine Preventable Diseases, the rotavirus chapter begins on page 311. So in 1973, a virus particle was observed in the intestinal tissue of children with diarrhea. By 1980, rotavirus was recognized as the most common cause of severe gastroenteritis in infants and young children in the United States. It is now known that infection with rotavirus is nearly universal, with almost all children infected by 5 years of age. In the pre-vaccine era, rotavirus was responsible for up to 500,000 diarrheal deaths worldwide and 20 to 60 deaths per year in the United States. Here you can see a picture of rotavirus. The virus was subsequently called rotavirus because of its similarity in appearance to a wheel. Rota is Latin for wheel. Rotavirus is a double-stranded RNA virus. The virus is composed of 3 concentric shells that enclose 11 gene segments. The outermost shell contains 2 important proteins, VP7 or G protein and VP4 or P protein. And these 2 proteins define the serotype of the virus and are responsible for inducing the neutralizing antibody that's involved in immune protection. Now, between 1996 and 2005, 5 strains of rotavirus, G1 through G4 and G9, accounted for 90% of the culture isolates from children younger than 5 years in the United States. Out of these, the G1 strain accounted for more than 75% of the isolates. Rotavirus is very stable and may remain viable in the environment for weeks or months if not disinfected. The immune correlates of protection from rotavirus are poorly understood. As mentioned, serum and mucosal antibodies against VP7 and VP4 are probably important for protection from disease. Cell-mediated immunity probably plays a role in recovery from infection and in protection. Now, recovery from a first rotavirus infection usually does not lead to permanent immunity. After a single natural infection, 38% of children are protected against any subsequent rotavirus infection. 77% are protected against rotavirus diarrhea, and 87% are protected against severe diarrhea. A reinfection can occur at any age. Subsequent infections confer progressively greater protection and are generally less severe than the first. The incubation period for rotavirus disease is short, usually less than 48 hours, and the clinical manifestations of infection vary and really depend on whether it's the first infection or reinfection. The first infection after 3 months of age is generally the most severe. Infection may be asymptomatic. It may cause self-limited watery diarrhea or may result in a severe dehydrating diarrhea with fever and vomiting. Up to 1/3 of infected children may have a temperature greater than 102 degrees Fahrenheit. The gastrointestinal symptoms usually resolve in 3 to 7 days. The reservoir of rotavirus is the gastrointestinal or GI tract and stool of infected persons. Rotaviruses are shed in high concentrations in the stool of infected persons. Transmission is by the fecal-oral route, both through close person-to-person contact and by fomites, such as toys and other surfaces contaminated by stool. In temperate climates, the disease is more common during the fall and winter months. In the U.S., before a vaccine was available, annual epidemics peaked in the Southwest during November and December and progressed to the Northeast by April or May. This infection is highly communicable, as evidenced by the nearly universal infection of children by 5 years of age in the pre-vaccine era. Infected persons shed large quantities of virus beginning 2 days before the onset of diarrhea and for up to 10 days after the onset of symptoms. So this slide shows the enormous disease burden of rotavirus in the United States before vaccines and the routine immunization of infants. Rotavirus was annually responsible for 3 million infections, more than 400,000 physician visits, 200,000 emergency department visits, 55,000 to 70,000 hospitalizations, and 20 to 60 deaths. All of this adds up to $1 billion in direct and indirect costs. Currently, there are 2 rotavirus vaccines licensed for use in the United States. Both are live attenuated vaccines. RV5, or Rotatech, is manufactured by Merck and was licensed by the Food and Drug Administration, FDA, in February 2006. RV5 contains 5 reassortant rotaviruses developed from human and bovine parent rotavirus strains. The term reassortant means that the vaccine viruses consist of viruses that have exchanged genetic segments between different strains. RV1 or Rotarix is manufactured by GlaxoSmithKline and was licensed by the FDA in April of 2008. RV1 contains 1 strain of live attenuated human strain type rotavirus. Neither vaccine contains preservatives or thimerosal. So in the main phase 3 RV5 clinical efficacy evaluation, which was conducted in Finland and the United States, the efficacy of the 3-dose series against G1 through G4 rotavirus gastroenteritis of any severity was 74%. Against severe G1 through G4 rotavirus disease, it was 98% during the first full rotavirus season after vaccination. Severe rotavirus gastroenteritis is defined by severity of fever, vomiting, diarrhea, and changes in behavior. In a large healthcare utilization study evaluating children during the first 2 years of life, RV5 vaccine reduced the incidence of office visits for G1 through G4 rotavirus gastroenteritis by 86%, emergency department visits for that outcome by 94%, and hospitalizations for that outcome by 96%. Now, the main phase 3 clinical efficacy trials of RV1 were conducted in Latin America and Europe. In the Latin American study, the efficacy of the 2-dose series against severe rotavirus gastroenteritis to age 1 year was 85%. In the European study, the efficacy against severe rotavirus gastroenteritis was 96% through the first rotavirus season, and against any rotavirus gastroenteritis was 87%. In the European study, RV1 reduced hospitalization for rotavirus gastroenteritis by 96% through the second season. So you can see on the slide the upper and lower levels of those ranges for both rotavirus, any rotavirus gastroenteritis, and severe gastroenteritis are dictated by kind of the ranges for both brands of the vaccine. And so because of the similar estimates of efficacy and safety, the Advisory Committee on Immunization Practices does not state a preference for one vaccine product over the other. The vaccine should be administered as a series of either 2 doses of RV1 at ages 2 and 4 months or 3 doses of RV5 at ages 2, 4, and 6 months. The vaccination series for both vaccines may be started as early as 6 weeks of age. The ACIP developed age recommendations that vary from those of the manufacturers. ACIP recommendations state that the maximum age for the first dose of both vaccines is 14 weeks and 6 days. That's an off-label recommendation for RV5 since the product information, or PI, states a maximum age of 12 weeks. The maximum age for any dose of either rotavirus vaccine is 8 months and 0 days, so no rotavirus vaccine should be administered to infants older than 8 months, 0 days of age. This is an off-label recommendation for both vaccines because the labeled maximum age for RV1 is 24 weeks, and the labeled maximum age for RV5 is 32 weeks. As far as the interval, ACIP did not define a maximum interval between the doses. It is preferable to adhere to the recommended interval of 8 weeks between doses. If the interval is prolonged, the infant can still receive the vaccine as long as it is given on or before the 8-month birthday, 8 months of age. It is not necessary to restart the series or add doses because of a prolonged interval between doses. There are a few data on the safety or efficacy of administering more than one dose at one point in time, even partial doses close together. And so ACIP recommends that providers not repeat the dose if the infant spits out or regurgitates the vaccine. Any of the remaining doses should be administered on schedule, of course, but you don't repeat that dose that was spit out immediately. You can count it. The minimum interval between doses is 4 weeks. In addition, ACIP recommends that the rotavirus vaccine series should be completed with the same product whenever possible. Sometimes providers do not know the product that was previously administered, or do not have that product in their inventory. If that occurs, vaccination should not be deferred. In this situation, the provider should continue or complete the series with the product that is available. If any dose in the series was Rotatech, or if the vaccine brand is unknown, then a 3-dose schedule should be followed. Infants documented to have had rotavirus gastroenteritis before receiving the full course of rotavirus vaccinations should still begin or complete the 2 or 3-dose schedule following the age recommendations, because the initial infection may provide only partial protection against subsequent rotavirus disease. RV5 comes in a manufacturer-filled oral dosing tube. RV1 is supplied as a lyophilized vaccine that requires reconstitution. Only the diluent supplied by the manufacturer should be used. Both vaccines are administered orally. There are no restrictions regarding eating or drinking, including breastfeeding, after rotavirus vaccine is given. Breastfeeding does not appear to diminish the immune response to rotavirus vaccines, and rotavirus vaccine may be administered at the same simultaneously at the same visit as other vaccines. As with other vaccines, rotavirus vaccine is contraindicated for infants who are known to have had a severe allergic reaction to a vaccine component or following a previous dose of vaccine. Latex rubber is contained in the oral applicator of RV1, so infants with a severe allergy to latex should receive RV5. The RV5 dosing tube does not contain latex. Some post-marketing studies of these vaccines have detected an increased risk for intussusception following rotavirus vaccine administration, particularly during the first week following the first dose. As a result of this, in October of 2011, ACIP added a history of intussusception to the list of contraindications for rotavirus vaccines. We can talk a bit more about intussusception when I get to adverse events. Lastly, ACIP added severe combined immunodeficiency, often abbreviated SCID, as a contraindication to rotavirus vaccination in response to reported cases of vaccine-acquired rotavirus infection in infants with SCID. So severe combined immunodeficiency is a contraindication, but all other forms of immunosuppression are considered precautions. And looking specifically at one form of immunosuppression, HIV infection, there is limited data available from clinical trials on the safety of rotavirus vaccines in infants known to be HIV infected. These infants were clinically asymptomatic or mildly symptomatic when vaccinated. The limited data available do not indicate that rotavirus vaccines have substantially different safety profiles in HIV-infected infants as compared to infants that are not HIV infected. Some other considerations include that HIV diagnosis might not be established by the time the first dose of rotavirus vaccine is indicated. Only 3% or less of HIV-exposed infants in the U.S. will be determined to be HIV infected. And also, most importantly, the vaccine strains are considerably attenuated or weakened. So with HIV and other forms of immunosuppression, the decision to vaccinate really needs to be made on a case-by-case risk-benefit basis. Another precaution, likewise, rotavirus vaccine should generally not be administered to infants with acute, moderate, or severe gastroenteritis. However, infants with mild acute gastroenteritis or other mild illnesses may be vaccinated. The term adverse event refers to a clinical outcome that has been observed but has not been definitively associated with a specific vaccine. And for rotavirus vaccine, one adverse event that has generated much attention is intussusception. With respect to newer vaccines, RV1 and RV5, extensive investigation was conducted pre-licensure because of the observation of this outcome from previous rotavirus vaccines used in the 1990s, which are no longer licensed. For the newer vaccines, the phase 3 clinical trials of both were very, very large, over 60,000 infants each, and they were large so that they could study this outcome, which occurs at a baseline rate. This is basically an anatomic condition that occurs when one segment of the intestine telescopes into the other one. And so these trials were very, very large to be able to study the occurrence in vaccine recipients as compared with placebo recipients. And it turned out that no increased risk of intussusception was observed for either vaccine in the pre-licensure trials. Now, post-licensure evaluations of RV1 in Mexico did identify a low-level increased risk of intussusception in week 1 after dose 1. Similarly, in Australia, a possible risk was identified with both RV5 and RV1, although this was based on small numbers of cases, which, to summarize, around 1 to 3 excess cases per 100,000 first doses is what has been determined from these post-licensure studies. Other post-licensure activities, VAERS reports can generate data, and it was reported that intussusception events do cluster in the 3 to 6 days following RV5 as opposed to an earlier period of time following the vaccine. And so VAERS data always has to be taken with a grain of salt because it's not controlled data. There has been some follow-up data from the vaccine safety data link, which is controlled data that shows no increased risk of intussusception for RV5, although they were not able to exclude a risk of the magnitude observed in those post-licensure evaluations. And so we stand by our data expecting about 1 to 3 excess cases per 100,000 first doses, and that's what we have on our vaccine information statement. And also, just note, parents and healthcare providers do need to be aware of a possible low-level increased risk of intussusception following rotavirus vaccine. We think this can be identified through screening before vaccination for a history of intussusception. This slide outlines adverse reactions following vaccination. RV5 recipients had a small but statistically significant increased rate of diarrhea at 18.1% and vomiting at 11.6% in the first week following vaccination as compared to the placebo group. Also, greater rates of otitis media, nasopharyngitis, and bronchospasm were reported. RV1 recipients had a small but statistically significant increased rate of irritability at 11.4%, cough or runny nose at 3.6%, and flatulence at 2.2%, occurring most frequently during the 31 days after vaccination. I will now transition to the second vaccine preventable disease and vaccine, hepatitis A and hepatitis A vaccines. For those of you following along in the Pink Book, the hepatitis A chapter begins on page 135. The first descriptions of hepatitis A are generally attributed to Hippocrates. Outbreaks of jaundice, which were probably hepatitis A, were reported in the 17th and 18th centuries. And at the time, hepatitis A was called infectious hepatitis. And this was first differentiated from hepatitis B in the 1940s through the development of a serologic test that definitively identified hepatitis B as a virus. So they were able to exclude hepatitis B. By the 1970s, further identification of the hepatitis A virus and the development of other serologic tests helped differentiate hepatitis A from other types of non-B hepatitis. And the hepatitis A vaccines were licensed in 1995 and 1996. The incubation period of hepatitis A is approximately 28 days, although it can range from 15 to 50 days. The clinical course of acute hepatitis A is indistinguishable from that of other types of acute viral hepatitis. The illness typically has an abrupt onset of fever, malaise, anorexia, nausea, abdominal discomfort, dark urine, and jaundice. Clinical illness usually does not last longer than 2 months, although 10 to 15% of persons do have prolonged or relapsing signs or symptoms that can last up to 6 months. The likelihood of symptomatic illness from hepatitis A infection, virus infection, is directly related to age. In children younger than 6 years of age, about 70% of infections are asymptomatic. In older children and adults, infection is usually symptomatic, with jaundice occurring in more than 70% of patients. Humans are the only natural reservoir for the virus. There are no insect or animal vectors. HIV infection is acquired primarily by the fecal-oral route, either person-to-person contact or ingestion of contaminated food or water. There's no appreciable seasonal variation in hepatitis A incidence. Viral shedding persists for 1 to 3 weeks. And infected persons are most likely to transmit hepatitis A virus 1 to 2 weeks before the onset of illness, when hepatitis A virus concentration in the stool is highest. This risk then decreases and is minimal the week after the onset of jaundice. Inactivated whole virus hepatitis A vaccines are available from 2 different manufacturers. Havrix vaccine is manufactured by GlaxoSmithKline, and Merck manufactures Vacta. Both of these vaccines are available in 2 formulations, a pediatric and adult formulation. The pediatric formulation of both vaccines are approved for persons 1 through 18 years of age. The adult formulation is approved for persons 19 years of age and older. Both vaccines are effective in preventing clinical hepatitis A. The efficacy of Havrix in protecting against clinical hepatitis A was 94%. This was studies in 40,000 Thai children 1 through to 16 years of age who received 2 doses, living in villages with high HIV disease rates. The efficacy of Vacta in protecting against clinical hepatitis A was 100%. This was in 1,000 New York children, 2 to 16 years of age, who received 1 dose while living in a community with a high hepatitis A disease rate. In 2001, the Food and Drug Administration approved a combination hepatitis A and hepatitis B vaccine called Twinrix, manufactured by GlaxoSmithKline. Each dose of Twinrix contains 720 ELISA units of hepatitis A vaccine, which is equivalent to a pediatric dose of Havrix, and 20 micrograms of hepatitis B surface antigen protein, which is equivalent to an adult dose of Engerix B, which is the single component hepatitis B vaccine. The vaccine is administered in a 3-dose series at 0, 1, and 6 months. Appropriate spacing of the doses must be maintained to assure long-term protection from both vaccines. The first and second doses should be separated by at least 4 weeks, and the second and third doses should be separated by at least 5 months. Twinrix is approved for persons 18 years of age and older and can be used in persons in this age group with indications for both hepatitis A and hepatitis B vaccines. Let me also mention that in 2007, the FDA did approve an alternative schedule for Twinrix with doses at 0, 7, 21 through 30 days, and a booster dose 12 months after the first dose. Single antigen hepatitis A vaccine or single component hepatitis A vaccine may be used to complete a series begun with Twinrix and vice versa. A person 19 years of age or older who receives 1 dose of Twinrix may complete the hepatitis A series with 2 doses of adult formulation hepatitis A vaccine separated by at least 5 months. A person who receives 2 doses of Twinrix may complete the hepatitis A series with 1 dose of adult formulation hepatitis A or Twinrix 5 months after the second dose. A person who does begin the series with hepatitis A, with single antigen or single component hepatitis A vaccine may complete the series with 2 doses of Twinrix or 1 dose of adult formulation hepatitis A vaccine. And an 18-year-old needs to follow the same schedule using the pediatric formulation of the single component vaccine if they are going to be switching and mixing and matching between single component and Twinrix, which of course we don't recommend, but sometimes this does happen. All children without contraindications should be given the hepatitis A vaccine series. The first dose is routinely recommended at age 1 year. Vaccination should be completed according to the licensed schedule, and remember that there should be at least 6 calendar months between doses. So this vaccine series can be integrated into the routine childhood vaccination schedule. Children who are not vaccinated by 2 years of age can be vaccinated at subsequent visits. States, counties, and communities with existing hepatitis A vaccination programs for children 2 through 18 years of age are encouraged to maintain these programs. So this focuses on initiation of the series perhaps after 2 years of age. In these areas, efforts do need to focus on routine vaccination of children 12 months of age. So that's where the focus should be on the 1-year-olds, but it can enhance and not replace ongoing programs directed at a broader population of children. In areas without the existing hepatitis A vaccination programs, catch-up vaccination of unvaccinated children that initiate after 2 through 18 years of age, can be considered. Such programs might especially be warranted in the context of increasing incidence or ongoing outbreaks among children or adolescents. For adults, adults need to be assessed if they are at increased risk for hepatitis A and offered vaccine accordingly. So there are risk-based recommendations, and that's demonstrated by the purple bar surrounded by the red box on this slide that indicates recommendations based on risk factors for certain populations. And so that's the age-based figure for the adult schedule. Here is the risk-based, the list of conditions, figure 2 for the adult schedule, which outlines what some of these high risks are. And then this slide also outlines what the risk groups are. So persons at increased risk include international travelers, close contacts with an international adoptee from a country of high or intermediate endemicity. What endemicity means is a high or intermediate, or it means a stable rate of infection, in this case hepatitis A in the population. Men who have sex with men, persons who use illegal drugs, persons who have a clotting factor disorder, persons with occupational risk, and persons with chronic liver disease, including hepatitis C. So with respect to international travel, all susceptible persons traveling to or working in countries that have a high or intermediate risk of hepatitis A virus infection should be vaccinated. These are the areas in red, blue, and green on this map. Vaccination is not indicated for travelers to countries in which endemicity is low and which are yellow on this map. Data are not available regarding the risk for hepatitis A for persons traveling to certain areas of the Caribbean, although vaccine or IG should be considered if travel to areas that have questionable sanitation is anticipated. The first dose of hepatitis A vaccine should be administered as soon as travel is considered. When unvaccinated healthy persons 1 through 40 years of age are considered 1 dose of vaccine administered any time before departure can provide adequate protection. And the series should be completed following the recommended schedule or upon return. For unvaccinated adults older than 40 years of age, for immunocompromised persons and persons with chronic liver disease that are planning to travel in 2 weeks or sooner, they should receive the first dose of vaccine and also can receive immune globulin at the same visit. Administer IG and vaccine using separate syringes at different anatomic sites. Pre-vaccination testing may be considered for older travelers or for younger persons in certain populations. In 2009, ACIP recommended hepatitis A vaccination for all unvaccinated persons who anticipate close personal contact, such as household contact or regular babysitting, during the first 60 days after arrival of an international adoptee from a country of high or intermediate endemicity. The first of the 2 doses should be administered as soon as the adoption is planned, ideally at least 2 weeks before the arrival of the adoptee. Hepatitis A vaccination is not routinely recommended for healthcare personnel, persons attending or working in child care centers, or persons who work in liquid or solid waste management, for example, sewer workers or plumbers. These groups have not been shown to be at increased risk for hepatitis A infection based on their occupations. ACIP does not recommend routine hepatitis A vaccination for food service workers, but vaccination may be considered based on local epidemiology. Hepatitis A infection produces lifelong immunity, so there is no benefit of vaccinating someone with serologic evidence of hepatitis A infection. But the risk for adverse events following vaccination for these persons is not higher than a serologically negative person. So as a result, the decision to conduct pre-vaccination testing should be based on the prevalence of immunity, the cost of testing and vaccinating, and the likelihood that testing might interfere with initiating vaccination. Testing of children is not indicated as the expected prevalence of infection is low. Serologic testing may be cost-effective for adults who were born in or lived for extensive periods in areas with endemic infection, older adolescents, and adults in certain populations such as American Indians, Alaskan Natives, Hispanics, or adults in certain groups with high prevalence of infection, and adults 40 years of age and older. Post-vaccination testing is not indicated because of the high rate of vaccine response in children and adults. Hepatitis A vaccine should not be administered to persons with a history of a severe allergic reaction to a vaccine component or following a prior dose of vaccine. Vaccination of persons with a moderate or severe acute illness should be deferred until the person is no longer moderately to severely ill. So the first bullet on the slide is a contraindication, and the second one is a precaution. The most commonly reported adverse reaction following vaccination is a local reaction at the injection site, including pain, redness, or swelling. These reactions have been reported in 20 to 50% of recipients. The symptoms were mild and self-limited. Systemic reactions like malaise and fatigue were observed in fewer than 10% of vaccine recipients, and no serious adverse reactions were reported. Hepatitis A containing vaccine should be stored in the refrigerator between 36 and 46 degrees Fahrenheit, which is equivalent to 2 to 8 degrees Celsius. We frequently hear about vaccine administration errors related to the wrong formulation being administered. Pediatric formulation administered to an adult and vice versa. So an important handling strategy to prevent these errors, including storing the vaccine formulations separately, but in their original packaging, because when pediatric and adult formulations are mixed together in the same bin or area, it is easy for staff to grab and administer the wrong formulation. And so with that, I will conclude and turn the microphone back over to Dr.
Thank you very much, Dr. Kroger. Let me now give you some continuing education information before we address the questions you sent us. The course code for today's program you'll need for CE application online is WC2645-071316, the latter which is today's date. The verification code is Hep A-16. The CE credit expires August 15th of 2016. The instructions are available in the resource pod how to use this program. So let us go to the questions you've given us. We'll leave the course code and verification code as well as the CE credit date up there for you. Dr. Kroger, a question we received from one of our listeners was that if either rotavirus vaccine, RV1 or RV5, is given at another facility, the child then comes to your facility and you have only the other vaccine, not the one they first received as the first dose. You have the other vaccine. Can you complete the series with the other vaccine?
Yes, you can do that. So in that sense, the vaccines are interchangeable. What you need to keep in mind is, and is specific to this scenario that's mentioned, is that one of the vaccines will be RV5, Rotatech, and so because of that, you need to have a full 3 doses as a total of 3 doses. But yes, you can count the vaccine that was administered at that first clinic as the first dose, and administer dose number 2 in your clinic.
Thank you. Another question we received, and we commonly have heard it on email as well, is if the first dose of rotavirus vaccine is inadvertently administered after the minimum age for the first dose, let's say at 15 weeks or older, should the vaccine series be completed?
Yes, you can. Now, if someone has not yet received that dose, if someone comes to your office and they're beyond the maximum age for dose number 1, we do not recommend that this dose be administered. And the reason for that recommendation comes from our observations from the rotavirus vaccine that's no longer used. RotaShield back in the 1990s was associated with intussusception. Intussusception generally occurs in middle infancy. That's when baseline rates of intussusception, and many things can cause in its intussusception. It's multifactorial, and it's not uncommon, but that's when that usually occurs. And so when RotaShield was studied, it was noted that intussusception was occurring after a first dose administered late. And so we do not recommend administering first doses of this vaccine late, beyond that maximum age for the first dose, which is 14 weeks, 6 days. However, if that vaccine dose happens to have been given late, you can continue with the series. The association has not been observed, and you can continue giving the doses beyond that date.
Okay, thank you very much. Question about hepatitis A. Can you use 2 doses of pediatric hepatitis A vaccine for an adult if you don't have any adult dose formulation available?
So, of course, this is another situation where we don't recommend you do this as a matter of routine. You should try to use the formulation that is licensed for the particular age cohort. But if you're in a circumstance where you're going to miss an opportunity to vaccinate, it is okay to do this. We don't like recommending it, but sometimes we understand that happens. But there are a couple things you must keep in mind. If you're going to do this, you have to give this as 2 separate injections. We don't want you mixing. These vaccines are available in single-dose formulations, and so we don't want you to kind of mix the components of 2 single-dose formulations into one combined volume. There are risks to doing that from contamination, and it's outside of good administration practices. So really, you have to draw your half dose up, administer, and then draw another half dose up and administer. So it involves 2 shots. And it's not something we routinely recommend, but we don't want you to miss an opportunity to vaccinate either.
Okay, thank you. Question, if a person does not know whether he or she received hepatitis A vaccine as a child, should you vaccinate the person if they're going to be a traveler or have other risk condition, or do serology?
So again, this is a decision. In a way, you don't know whether the vaccine dose was administered as a child, and we don't accept self-report for hepatitis A vaccine, so no documentation the dose wasn't given. So this becomes the context or a scenario of pre-vaccination serology. And again, that should be based on risk of disease based on the characteristics I described, where the person came from originally, their own personal risks, or the chance that they have been naturally infected with hepatitis A. When in doubt, I would say give a dose of the vaccine. As mentioned, if someone is already immune, it doesn't hurt to give a dose of hepatitis A vaccine, and that is whether they're immune from past disease or from a previous dose of vaccine that you're not sure of. So yes, give a dose of the vaccine if you're unsure and there's a current risk.
Okay, and the question, sort of a two-part question, is can you go into further why sewage, solid waste disposal, and they say even people cleaning toilets in office facilities or other places are not at increased risk of hepatitis A, yet we vaccinate all children routinely. Can you comment on the risk and the decision to vaccinate all children?
Well, I don't have numbers at my disposal, but I can tell you that the epi data that we have shows that there is not, it's been looked at. There have been 3 serologic surveys that were conducted among U.S. wastewater workers, and they just didn't find an increase in the prevalence of antibody to hepatitis A identified among these wastewater workers. So, and I'm assuming it would include people that clean toilets as well as sewer workers, plumbers, as I mentioned. And we don't know of any work-related instances of hepatitis A virus transmission occurring among wastewater workers in the U.S. So the data, seem to indicate that it's not a risk, which is why we don't recommend the vaccination.
Okay. Could you comment in the setting of a hepatitis A outbreak, if a person is concerned about their exposure but can't quite quantify it, how are decisions made as to which persons are vaccinated in an outbreak setting for hepatitis A?
That's typically recommended at the the state or local level. Basically the agency that is really on the front lines in dealing with the outbreak. Oftentimes CDC is consulted in outbreaks, but not always, and it really does fall to state and local health to determine and conduct the outbreak investigation, find out who was exposed. This occurs often in the food service industry. So that type of investigation really has to be done. I believe vaccination history is a part of that process, and they gauge what the risk is for everyone that was exposed and make their vaccination recommendations accordingly. There are certain groups, such as persons 41 years of age and older, persons with chronic liver disease, of course, persons that have contraindications to vaccination. For a dose of IG, in addition to hepatitis A vaccine, this is in persons that are unvaccinated, but in addition to a dose of hepatitis A vaccine, or if they can't receive the vaccine because of the contraindication, as I mentioned, just a dose of IG. But there are certain groups for whom IG does become a consideration. But the primary tool for post-exposure prophylaxis is the vaccine, now hepatitis A vaccine.
Okay, thank you. There's a question here that if a person's had the series, both doses of hepatitis A vaccine, and then someone's done a serologic test for immunity and finds non-evident or below definable level of immunity antibody, would one give another dose of vaccine?
That's a great question. I haven't heard that one in the context of hepatitis A before. I know for many other vaccines, when you have documented evidence of vaccination, you can, for all intents and purposes, ignore post-vaccination serology, provided the doses were administered at the age-appropriate times. I haven't heard of this occurring with hepatitis A before. It is such an effective vaccine. I wonder if it has occurred. Probably it has occurred in the past.
I'm unaware of a specific CDC recommendation for this instance, defining criteria of immunity. I can tell you that another dose of hepatitis A vaccine wouldn't hurt if there's any uncertainty as to the past vaccination records. So that is an option to give another dose of vaccine. But I'm not sure if there's a specific published recommendation on this.
And I'm not aware of one either, and it's something we'll have to check for the questioner and put it on writing on our website. In what circumstances would one want to use the accelerated schedule or alternative schedule for Twinrix vaccine?
Great question. If travel is imminent, because with the standard Twinrix schedule, right, at 0, 1 week, and 6 months, or 0, 1 month, 6 months, you may not be able to get in 2 doses if you're going to travel in just under a month, whereas with the expedited Twinrix schedule of 0, 7 days, 21 days at the lower end of that range for the 3rd dose, you could get those 3 doses of Twinrix in for travel using that expedited schedule. And so that would be kind of a worthwhile schedule for someone traveling in less than a month. Keep in mind that you do need to, if you use an expedited schedule like that, it is a 4-dose series, so you have to remember to give that 4th dose at the 12-month point in time from the start of the series.
Okay. Question here, and I think you've answered a variation of this. What action should be taken if a pediatric hepatitis A vaccine dose is given in error to an adult?
Yes, so if a pediatric formulation of Hep A is given to an adult, that is considered a subsized dose. It should not be counted as valid. And just remember, adults are 19 years of age and older in this for hepatitis A specifically. So again, that dose should not count. If that error is detected on the same day, it would be acceptable to administer a second half a dose, a second pediatric formulation dose. Sometimes that comes up, often in the context, as mentioned in the question earlier, with providers that only have one formulation, but it is acceptable if the error is detected on the same day. If the error is detected the next day or later, you have to give your repeat dose, and it can be given immediately. There's no spacing required for hepatitis A vaccine because it's an inactivated vaccine, but you do have to give the repeat dose, and you should give the adult dose to an adult. So that's what you have to do. That's the difference. If you catch it on the same day, you can give the second half. But